So today's discussion topic is multinodular goiter. Hello everyone, this is Joanne. Welcome to my YouTube channel. Very nice to see you back here again. So let's dive into the topic. But before that, if you haven't subscribed to my channel, please do subscribe because a lot of effort goes into these videos. Yeah, so multinodular goiter, most often seen thyroid swellings are multinodular goiter. This is why this topic is important. Most of the endemic goiters are MNG and no thyroid swelling starts as MNG, right? So very often it starts as a smooth hyperplastic swelling and it slowly becomes nodular. So in these patients, you can see a history of long duration, right? 5 or 10 years, they will say they had the swelling. And most of the retrosternal goiters are also MNG. Now, what is goiter? Goiter is just any swelling in the throat. So there can be physiological goiter when there is puberty. In pregnancy, it is around 50 times enlarged. Menstrual cycle, there can be changes, which is due to the estrogenic stimulation. So what is the pathology of this? Fluctuating TSH levels. So TSH levels, when it increases, there is follicular hyperplasia, and when it decreases, there is regression. So fluctuating TSH levels is the main pathology. So what happens? There is a varying response of the follicles, of the clones of follicles to thyroid stimulating hormone. So it is usually bilateral, that is, both the lobes of the thyroid are involved. So what is the etiology? So first let us look at endemic goiter. So in endemic goiter, the etiology is iodine deficiency, right? So endemic means what? Endemic means more than 10% of the people in a geographic area are affected. So that is what endemic means. So where is this endemic goiter found? Where do we see this? It is in the hilly areas, right? So why is that in hilly areas that there is endemic goiter, right? So what is the main source of iodine for us? The main source of iodine for us is water, right? So in hilly areas, see, we have rainwater, which is pure H2O, right? This does not contain iodine, right? So the water that we drink is mineralized water, right? So this iodine is our main source. So in people in hilly areas, when they take water from the ponds, etc., their source of iodine is not met. They also do not have access to seafood and such. So that is why they have iodine deficiency, right? And they get endemic goiter. Okay, so for them we can give supplements in the form of iodized salt. But the thing is that we here in the coastal areas, we do not require supplement as iodized salt, but we still intake it. So iodides in excess, they can cause suppression of the thyroid. They can inhibit the thyroid, right? They can cause thyroid constipation, thyroid diarrhea. They can actually inhibit the thyroid, and this can result in goiter. So what will happen in endemic goiter? In iodine deficiency endemic goiter also, this will turn into an MNG, okay, because of the variable TSH stimulation. The next is inherited conditions. So in this we will be looking at something known as the Pendred's syndrome, right? So Pendred's syndrome is an autosomal recessive inherited condition, right? And Pendred's syndrome is associated with peroxidase deficiency. So an enzyme is deficient and the enzyme is peroxidase. Also there is a protein, that is pendrin, that is deficient. Alright, so this is the same protein in the ear as well. So these patients will complain of deafness as well. So pendrin is an anion transporter, note that, and the enzyme deficient is peroxidase, okay, resulting in hypothyroidism. So the same transporter is in the inner ear, so these individuals have deafness. So this will also become a multinodular goiter later on. Now let us look at the goitrogens. So what are the goitrogens? Certain vegetables like cauliflower, cabbage, right? These vegetables, they contain thiocyanates. They contain perchlorates. So this will inhibit the thyroxine synthesis, resulting in hypothyroidism or resulting in goiter. Looking at the goitrogenic drugs, so we have lithium. Okay, it is a mood stabilizer. It is used widely in psychiatry. What else do we have? We have the anti-tubercular drugs, right? We have isoniazid. And in the heart, the anti-arrhythmic drug, which is amiodarone. This is also goitrogenic, alright? Then we have another group which is the anti-thyroid drugs. So they will cause hypothyroidism by causing an excess of TSH release. So TSH is in excess and this will result in a multinodular goiter. Next is a separate entity, okay, autoimmune thyroiditis. But this can also lead to multinodular goiter. So I will discuss it here. So autoimmune disease, right? So we have antibodies. So there are anti-thyroid antibodies in this patient. So what happens is that these anti-thyroid antibodies destroy the thyroid follicles. So there is anti-thyroid antibodies, right? And these antibodies are secreted from the B lymphocytes and these destroy the thyroid follicles. So what happens in these patients is that as the thyroid follicles are destroyed, there is a transient increase in the T3, T4 levels, alright. So this will result in thyrotoxicosis. So this thyroiditis will present with pain and there is toxicosis. So as I said earlier, when the follicles are destroyed, what will happen is that there is a stored thyroid hormones, okay, which are released, okay, into the circulation. Now this will result in thyrotoxicosis. This is known as Hashimotoxicosis. So this is in the initial phase, right? So initially, but what happens later is that there will be complete destruction of the follicles, right? So there will be more and more destruction of the follicles, and then what will happen is that there is no more of these hormones to be released, all right? So this will result in scar formation of the thyroid and there will be a multinodular goiter formation. So now let us discuss about the pathogenesis of nodularity. How are these nodules formed in multinodular goiter? Alright, so we know it is because of TSH stimulation. TSH stimulation causes diffuse hyperplasia, which is reversible if it is ceased, right? When TSH is withdrawn, there is regression of the follicles. So there is basically a fluctuating level of TSH. So because of this fluctuating TSH, there is a varied response. There are active lobules and there are inactive lobules, and the active lobules become more vascular till they become hemorrhagic, and there is a central necrosis. These necrotic lobules, they will coalesce to form nodules. Now repetition of this process will lead to formation of nodular goiter. So now we can discuss about the clinical features. So what is the age of presentation? It is in middle-aged females. This is more common. So what is middle-aged? 40 to 60 years, right? So more than 40 years of age. Females, more predominant. Now, so there is history of a long-standing swelling. There is history of a swelling for a long time, say for 5 years or 10 years, right? So there is a progressive swelling for a long time, right? There is a multiple nodular swelling. So there is a bossulated appearance or a multiple nodular swelling. Now this swelling is non-tender, there is no pain, right? It is firm and there can be calcification. It can be calcified hard. So if there is hemorrhage or if there is necrosis, then the swelling can be soft. It can be tender, there can be pain, right? And in some patients, there is this one nodule which is larger than the other nodules. So this nodule is palpable, the rest of the thyroid is also palpable, but this nodule is larger. So this is the dominant nodule of the multinodular goiter. Now what are the complications of multinodular goiter? This will include cosmetic complication. So the appearance of the person can be a problem, right? The swelling. So next is the compression symptoms. So this swelling can compress the trachea and it can cause breathing difficulties, right? So the largest multinodular goiters are due to endemic goiter, and this can cause compression symptoms when the swelling is very large, and in the trachea there can be airway obstruction. In the esophagus there can be swallowing difficulties, right? And long-standing goiters, long-term multinodular goiters, this can cause softening of the tracheal cartilages and it can result in a condition which is known as tracheomalacia. Then we have hemorrhage as a complication. So there can be sudden enlargement of the thyroid, there can be sudden hemorrhage. Next complication is thyrotoxicosis. So thyrotoxicosis can occur due to long-standing multinodular goiter. And this thyrotoxicosis that occurs as a result of long-standing multinodular goiter is known as secondary thyrotoxicosis. Why is this secondary thyrotoxicosis? What is the primary thyrotoxicosis? Yes, it is Graves' disease. So Graves' disease is the primary thyrotoxicosis. See, but Graves' disease occurs in the younger people, right? In the younger patients. But MNG, it occurs in older populations. So this is more dangerous, right? The secondary thyrotoxicosis due to long-standing MNG, this will be more dangerous. And it can lead to cardiac symptoms such as atrial fibrillation. So next complication that we have is carcinoma of thyroid. So 1% of the patients, they can develop a follicular carcinoma of the thyroid. Can be a retrosternal extension of the thyroid. Discussing the investigations, we take a thyroid function test. So to check the level of the hormones, USG is taken, multiple nodules can be seen, a hemorrhagic area with nodules and calcification can be seen, malignant transformation is picked up, lymph nodes can be observed, architecture of thyroid can be seen. An X-ray soft tissue neck is taken, lateral and antero-posterior view. Alright, so why is this taken? This is to visualize the compression of the trachea in these antero-posterior and lateral views. Alright, so we can see the characteristic appearance of trachea. So there is this term which you have to remember, that is scabbard trachea. Alright, that is this characteristic appearance of trachea which is seen on the X-ray. Okay, so now we have to do an ENT examination. So why do we do an ENT examination? So in 7 to 8%, alright, of 7 to 8% of the normal people, they have unilateral vocal cord palsy. Okay, so tell me what will happen if during surgery, the surgeon accidentally damages the other vocal cord also. Then there will be bilateral vocal cord palsy, isn't it? So in that case, the patient will have to then go for tracheostomy. So to avoid this, we do an ENT examination to find out whether there is already existing vocal cord palsy. So CT or MRI can be taken when there is suspected retrosternal goiter. Otherwise, it is not required. So also we check for TPO antibodies, because these are the antibodies which are responsible for Hashimoto's thyroiditis, I told you, which will also lead to multinodular goiter. So we check those levels. We can do an FNAC to look for any malignant transformation. So now let us discuss the treatment options. So how do we treat a patient with multinodular goiter? So if the patient is asymptomatic, then we don't need to operate on the patient, right? Only if the patient is symptomatic, that is the patient shows some pressure symptoms, or there are signs of underlying malignancy, or there is a cosmetic issue. In that case, we can go for surgery. Now, so the choice of surgical treatment in a multinodular goiter is either total thyroidectomy or a subtotal thyroidectomy. So if it is total thyroidectomy, then there is immediate and lifelong replacement with thyroxine. But in subtotal thyroidectomy, there is some of the tissue which is left behind, so replacement with thyroxine is not required. And in subtotal thyroidectomy, the complication of hypoparathyroidism, that is all avoided. So since some thyroid tissue is left behind, replacement with thyroxine may not be required. This is one of the advantages of subtotal thyroidectomy. Also in this procedure, inferior thyroid artery is not ligated. So the advantage is that there is no recurrent laryngeal nerve injury, because we know recurrent laryngeal nerve is associated with the inferior thyroid artery. And also the parathyroid supply is intact. So we know branches from the inferior thyroid artery supply the parathyroid. So that is also not affected. So now what are the merits of total thyroidectomy? So in subtotal thyroidectomy, there is a problem of recurrence, whereas in total thyroidectomy, this problem of recurrence is avoided. Alright, so many surgeons now prefer total thyroidectomy. What is the prevention? So prevention, one of the prevention methods is obviously to supplement iodine, okay, to prevent the iodine deficiency. So iodized salt can be given, and milk, egg, seafood, etc. can be given to prevent iodine deficiency. Hyperplastic goiter, give thyroxine so that TSH is suppressed. So we can also avoid goitrogens such as cabbage, cauliflower and the goitrogenic drugs. So that is also a preventive measure that we can take. So if there is a retrosternal thyroid, what do we do? What we do is a median sternotomy. So that was the whole topic of multinodular goiter. Thank you.